So if you walked into a doctor's office today complaining of like a standard earache, and the very first thing the doctor did was ask you to stand up, close your eyes, and walk in a straight line across the room.
You'd be incredibly confused.
Right. You'd probably think they were in the wrong profession or giving you a sobriety test. I mean, you came in for a pain in your ear.
Yeah, it feels completely disconnected from the problem you brought to them, but it actually reveals this fundamental truth about how our anatomy is built.
Because the body doesn't actually respect the artificial boundaries we try to put on it.
Exactly. It just doesn't.
And that invisible web of plumbing and wiring is exactly what we are exploring in today's deep dive. We have a genuinely fascinating set of source materials today.
We really do.
We are looking at actual handwritten clinical notes that are used to train medical students. And specifically, these are checklists for what they call short cases in an ENT examination. So ear, nose, and throat, plus the head and neck.
Yeah, and these notes serve as a phenomenal artifact. I mean, they give us a literal step-by-step roadmap of how a physician is trained to conduct a physical exam.
It's mapping out the logic of a medical investigation.
Right, exactly.
And our mission today is to decode that logic.
Yeah.
So just to be clear, we aren't here to give medical advice to anyone listening. The goal is to understand the detective work that doctors are trained to do in the clinic.
Because when you read through the steps a student is forced to memorize, you realize very quickly that medicine is, well, it's all about tracing connections.
It really is. And we start, logically enough, at the side of the head with the ear.
Yeah, and the initial steps for the ear immediately dispel the myth that an ear exam just involves, sticking a little plastic funnel with a light into the side of your head.
Right.
A proper exam starts much earlier than that.
The progression taught here is just incredibly methodical. Like, the student is instructed to start with pure inspection and palpation, just looking at and feeling the outside of the ear and the surrounding tissue.
Just using their hands and eyes?
Yeah, and then they do an examination without speculum, just looking into the ear canal with the naked eye. And only after all that do they finally use the speculum, which is that little funnel tool, followed by an otoscopy.
It's a very deliberate buildup.
It reminds me of a good home inspector. I mean, you don't walk up to a house and immediately burst through the front door into the living room.
Right, you walk the perimeter.
Exactly. You walk the perimeter, you check the foundation, and you inspect the exterior siding before you ever cross the threshold.
And that's because the exterior of the ear, the pinna and the skin behind it, can tell you a massive amount about underlying congenital issues, deep infections, or trauma.
Oh, wow.
Like if the ear is pushed forward and the skin behind it is red and swollen, you might be looking at mastoiditis, which is a severe infection of the skull bone, before you've even looked at the eardrum itself.
That makes a lot of sense. But this is where the clinical roadmap takes a really hard left turn. Right after examining the actual ear structures, the student is suddenly instructed to check the patient's gait, how they walk.
Right, the walking test.
Yeah, they have to do something called Romberg's test. They have to look for cerebellar signs and perform a fistula test. I'm just thinking, if I'm sitting on the exam table with a muffled ear, why is my doctor suddenly watching me walk across the room?
It's because the ear is doing double duty. We tend to think of it strictly as the organ of hearing, but it is simultaneously the primary organ of balance.
Which we totally take for granted.
Oh, completely. Deep inside the inner ear is the vestibular system. It consists of these tiny fluid-filled semicircular canals that act exactly like the gyroscopes inside your smartphone.
Okay, that's a great way to picture it.
Yeah, they constantly send electrical signals to your brain, telling it exactly where your head is oriented in three-dimensional space.
So if there is a massive infection or a structural lesion deep in the ear, it's going to throw off that gyroscope.
Precisely. If your vestibular system is compromised, your brain receives faulty spatial data, and your gait will become unsteady. You'll literally veer to one side when you walk.
Wow. And the Romberg test.
The Romberg test you mentioned capitalizes on this. The doctor has the patient stand with their feet together and then close their eyes.
Okay, so taking away the vision.
Exactly. By closing your eyes, you remove visual input from the equation, which forces your brain to rely almost entirely on those inner ear gyroscopes to stay upright.
Oh, I see.
So if the inner ear is failing, the patient will immediately sway or even start to fall over. It looks like a neurological exam, but it's actually testing the ear.
That structural hardwiring explains another really interesting check on this list. The doctor is instructed to look at the patient's eyes for something called nystagmus.
Ah, yes. Nystagmus is an involuntary, rapid flicking movement of the eyeball.
Like they're twitching.
Sort of, yeah. Because the vestibular system in the ear is intimately wired to the cranial nerves that control your eye muscles, a misfire in the inner ear will cause the eyes to slowly drift to one side and then sharply snap back to the center.
That is wild.
By closely observing the tiny movements of the eyes, the doctor is actually gathering critical data about the fluid dynamics deep inside the skull.
It's all just so interconnected. And we can't forget the tuning forks.
Oh, the tuning forks are classic.
Right. The training requires the student to perform tests called RINS, Weber, and ABC. In an era of MRI machines and digital scans, there is something incredibly cool about striking a vibrating metal fork to figure out why someone can't hear.
It is brilliantly analog. Those tuning fork tests are designed to figure out if hearing loss is a mechanical plumbing problem or an electrical wiring problem.
Meaning, is the ear canal simply blocked by fluid or wax, or is the auditory nerve itself damaged?
Exactly, because sound can travel through the air, but it also travels incredibly well through solid bone. If you strike a tuning fork and place the vibrating metal base directly onto the mastoid bone, that hard lump of bone right behind your earlobe, the sound vibrations completely bypass the outer ear canal.
Wait, really? It just goes straight through?
Yeah, it travels straight through your skull to the inner ear. That's called bone conduction.
So if a patient can hear the tuning fork when it's pressed against their skull, but they can't hear it when it's held next to their ear, the nerve is fine. The sound just can't get through the ear canal.
You've just diagnosed conductive hearing loss.
That is so elegant.
It really is. And the ABC test you mentioned, which stands for absolute bone conduction, involves the doctor placing the vibrating fork on the patient's mastoid bone and then quickly moving it to their own mastoid bone to compare.
So they use themselves as the baseline.
Exactly. It assumes the doctor has normal hearing, effectively using the doctor's own skull as the control group to measure the patient's nerve function.
That is amazing. But what's equally revealing is what the document tells the student not to do.
Right, the exclusions.
It explicitly warns no trigeminal plus corneal checks and no color vision tests. It's like the instructor knows an eager medical student might get carried away checking every single cranial nerve in the face, so they have to put up strict guardrails.
Well, a physical exam needs to be focused. Checking if a patient is colorblind won't tell you a single thing about their auditory or vestibular systems.
The medical training seems to be just as much about knowing what to exclude so you don't waste the patient's time.
100%.
So the ear section wraps up by checking the lymph nodes and doing an anterior rhinoscopy, which means looking into the front of the nose, which is the perfect anatomical bridge to the next major section of the checklist, the nose.
Moving right along.
Yeah, we're moving from the delicate neurological wiring of the ear to the heavy physical architecture of the face.
And the nose is an incredibly complex structural gateway. It's not just two holes in your face, it's the climate-controlled intake valve for the entire respiratory tract.
The visual inspection demanded here is intense though. The student must look from the front, the side above, and below. Then there's a specific instruction for the patient to take a deep breath for alar collapse, followed by a tip-up examination, then checking whether the airway is physically blocked, and finally testing their sense of smell.
That alar collapse check is a great example of dynamic anatomy. The ala are the fleshy, cartilaginous sides of your nostrils.
Okay.
When you take a sharp deep breath in, it creates a sudden pressure drop inside the nasal cavity.
Like a vacuum effect.
Exactly. If the cartilage on the sides of your nose is structurally weak, that negative pressure will literally suck the nostrils inward, collapsing the airway completely.
Oh, wow.
It's a physical failure. You can only diagnose while the system is actively working.
But just like the ear exam, the checklist for the nose takes a wild detour. Under the nose exam, the doctor is instructed to look inside the mouth for something called a Caldwell-Luke scar, and they have to perform teeth percussion, literally tapping on the patient's teeth. But the notes explicitly emphasize upper only. And then they have to use a stethoscope for chest auscultation to listen to the lungs.
It sounds random, right?
Totally. If I have a recurring nosebleed or severe nasal congestion, why is my doctor tapping on my upper teeth and listening to my chest?
This brings us to the interconnected plumbing of the human skull. Your upper teeth, specifically the molars and premolars, have deep roots that sit right at the floor of the maxillary sinus.
And the maxillary sinus is?
It's the large, hollow air cavity sitting inside your cheekbones, which drains directly into your nasal passage.
So the roots of your teeth and the bottom of your sinuses basically share a ceiling and a floor.
They often share a wonderfully thin, paper-like wall of bone, and in some people, the tooth roots actually poke up directly into the sinus cavity.
Yikes.
Yeah. So if you develop a severe sinus infection, a problem originating in the nose, the pressure and inflammation push down relentlessly on the nerves of those upper teeth.
Oh, so you might go to the dentist convinced you need a root canal when actually your sinuses are packed with fluid.
Exactly. Conversely, a severe infection in an upper tooth can eat through that thin bone, erupt into the sinus, and cause a massive nasal infection. Tapping the upper teeth sends a tiny shockwave up the root to help isolate where the inflammation is really localized.
That is so clever. And the Caldwell-Luke scar. Why are we looking for a scar inside the mouth for a nose problem?
Because of that exact anatomical relationship. A Caldwell-Luke procedure is an older type of sinus surgery. If a surgeon needed to clear out a diseased maxillary sinus, the most direct route wasn't always up the nose. It was cutting through the gum line above the upper teeth and going straight through the front wall of the cheekbone.
Goodness.
Right, so if a doctor sees that surgical scar tucked under your upper lip, they instantly know you have a major history of sinus disease.
It's all connected. And the logic for listening to the lungs.
The respiratory tract is one continuous, unbroken mucosal lining from the tip of your nostrils all the way down to the tiny microscopic air sacs in your lungs. It's the exact same tissue.
So if the top is mad, the bottom might be mad too.
Precisely. If a patient has severe nasal polyps or chronic sinus inflammation, there is a very high likelihood they also have lower airway reactivity, like asthma. You cannot successfully treat the top inch of a pipe if the bottom 3 feet are also inflamed.
This level of integration is just mind-blowing. The notes also detail checking the corneal reflex and trigeminal nerve. And for the eyes, they check vision, movements, and look for specific negative findings. The checklist explicitly states, no proptosis plus telecanthus prominent.
Right. Medical terminology there. Proptosis means a physical bulging of the eyeballs forward out of the skull. Telecanthus means the eye are spaced abnormally far apart.
Again, why would a nose issue cause your eyeballs to bulge or spread apart?
Because the sinuses completely surround the eye sockets. The ethmoid sinuses sit right on the bridge of the nose, directly between the eyes.
Right.
If a patient develops a massive nasal polyp, an aggressive fungal infection, or a tumor in that space, the pressure has nowhere to go. It will slowly push the delicate bony walls outward, literally displacing the eyeballs away from the center of the face.
Wow. The body really is a crowded place. There is zero wasted space.
Not at all.
So the nose section finishes up by checking the lymph nodes, looking at the back of the nasal cavity with a mirror, and incredibly, bringing back the tuning fork for the ear to do the Renz and Weber tests again. It just keeps circling back on itself.
You truly cannot examine one system without verifying the structural integrity of the systems bordering it.
Which carries us down from the respiratory tract to what feels like the metabolic engine room of the body, the neck. This section of the clinical notes focuses heavily on the thyroid and the submandibular areas.
Yeah, the thyroid is that butterfly-shaped gland resting low on the front of your neck, wrapped around your windpipe. It is essentially the gas pedal for your body's cellular metabolism. It dictates how fast or slow your entire system runs.
And the notes for examining the thyroid are incredibly thorough. The physical checks include inspection, palpation, percussion, and auscultation. The student is specifically told to listen to the neck with a stethoscope for bruits and murmurs.
A bruit is the physical sound of turbulent blood flow.
Okay, so like a rushing sound.
Exactly. If a thyroid is hyperactive, if the gas pedal is pushed to the floor and it's producing way too much hormone, the gland requires a massive increased blood supply to sustain that workload.
Oh, I see.
The blood rushes through the surrounding vessels so fast and so hard that it literally creates a rushing, whooshing vibration. The doctor isn't listening to your breathing, they are listening to the sheer velocity of your blood.
But if the thyroid is a gland in the neck, I have to ask about the next items on the checklist. The notes say the student must inspect the patient's hands for movements. They have to check the eyes for convergence and Pemberton sign, and they have to check the patient's shins for pretibial myxedema.
It sounds like they're checking everything but the neck.
Yeah. Why is an ENT doctor examining my hands and my shins for a lump in my throat?
Because hormones don't stay where they're manufactured. The thyroid dumps its hormones directly into your bloodstream where they travel to every single cell in your body. If you have hyperthyroidism, your central nervous system gets dangerously overstimulated.
And that causes the hands to shake.
Exactly.
Yeah.
That electrical overload manifests as a fine, uncontrollable tremor in the hands.
What about Pemberton's sign and convergence in the eyes?
Well, convergence is simply checking if the patient can cross their eyes to focus on a close object, which can be impaired by thyroid eye disease. But Pemberton's sign is an amazing mechanical test.
How does that work?
If a patient had a massive goiter, a hugely enlarged thyroid hidden deep in the neck, the doctor will ask them to raise both arms straight up in the air.
Just raise their arms, yeah.
When you raise your arms, your collarbones shift and physically squeeze that giant thyroid gland against your windpipe and your jugular veins. Right, the blood can't drain from the head, and within seconds, the patient's face turns bright red and puffy. By making the patient raise their arms, you're confirming a blockage in the neck.
It's pure physics. And what about the shins?
That's a classic symptom associated with Graves' disease, which is a specific autoimmune type of hyperthyroidism.
Okay.
The exact same rogue antibodies that are attacking the thyroid gland in the neck also happen to target the skin on the front of the lower legs. They cause a buildup of complex carbohydrates under the skin, creating this thick, swollen, waxy, almost orange peel texture on the shins, known as pretibial myxedema.
So by looking at the texture of the leg, the doctor is gathering vital systemic clues about the autoimmune battle happening in the neck.
Exactly right.
The notes also detail a specific examination from behind. The doctor is told to physically walk behind the seated patient to check for spine tenderness and to check for exophthalmos, which is assessing those bulging eyes by looking straight down from above the patient's forehead.
It gives you a much better angle to see the protrusion.
Makes sense. They also palpate the thyroid using Leahy's method and feel for neck nodes while having the patient actively shrug their shoulders.
Shrugging the shoulders strongly engages the trapezius muscle in the back of the neck. That muscle contraction physically pushes certain deep lymph node chains closer to the surface of the skin, making them much easier to feel.
Wow. So the doctor is actively manipulating the surrounding musculature to reveal what is normally hidden.
Yeah, it's brilliant.
And the notes detail a very similar process for the submandibular area, the space right under the jawline.
The submandibular glands are your major salivary glands. Because they share the exact same crowded real estate in the upper neck as the lymph nodes, if a patient has a calcium stone blocking a salivary duct or a swollen gland, the examination overlaps heavily with everything we just discussed.
And that shared real estate doesn't stop at the glands though, because if you trace those salivary ducts upward, you end up right inside our next major structural zone, the oral cavity.
Moving inside.
Yes, we've mapped the outside of the face, the nose, the ears, and the neck. Now, the checklist moves inside the mouth. And what strikes me about this section of the clinical notes is how incredibly tactile it is.
It absolutely has to be. The mouth is a dark, wet, highly complex cavern. Visual inspection just isn't enough. You have to feel the architectural integrity of the tissues.
The steps start with inspection, specifically instructing the student to avert upper-lower lip, literally pulling them outward and flipping them to see the hidden mucosa. Then they're told to measure something called trismus. And they don't just eyeball it, the notes emphasize measure with scale, meaning a literal ruler.
Trismus is essentially lockjaw, a severely restricted ability to physically open the mouth.
What causes that?
It can be caused by a massive infection, like a severe tonsil abscess, spreading to the chewing muscles, or even by an underlying tumor. Measuring the opening with a millimeter ruler gives the doctor an objective baseline.
Oh, so they can track it over time.
Exactly. If you come back the next morning and your mouth opening is 5 millimeters smaller, the doctor instantly knows the infection is spreading aggressively into the muscle tissue.
The physical checks here are intense. They percuss teeth again. If there's an ulcer, the doctor doesn't just look at it. They are instructed to palpate it, feeling the edges to see if it's soft or rock hard.
Which can be the difference between a simple canker sore and oral cancer.
Wow.
This is where bimanual palpation becomes heavily emphasized in the notes. Bimanual palpation means using two hands simultaneously. The doctor will place one gloved finger inside the patient's mouth, pushing down under the tongue, while the fingers of their other hand press press upward on the skin outside, directly under the jaw.
So they're sandwiching the floor of the mouth between their hands.
Exactly.
Yeah.
You are physically trapping the tissue between your fingers. A lump that feels vaguely puffy from the outside might suddenly reveal itself as a rock-hard, distinct mass when you push it up from the inside.
That is fascinating.
It's like finding a marble hidden inside a wet sponge. It is the only way to truly assess the depth and density of structures hidden under the tongue.
It's amazing how much diagnostic data is gathered just through touch.
And just to hammer home the holistic theme, during this oral exam, the student is instructed to check the spinal accessory nerve, look down the throat with a mirror, look up the nose again, and incredibly bust out the tuning fork to test the ear one more time.
They just can't put the tuning fork down.
No, because the symptom presenting in the mouth can literally be the unraveling thread that leads to a diagnosis in the ear.
Which brings us to a crucial pivot in this document. Up until now, these checklists have focused entirely on what the doctor is supposed to be checking. But the final page of these clinical notes shifts entirely to how they are checking it.
Right, the patient interaction.
Yes, the page is simply labeled commands, and it features a list of translated phrases in Urdu. This shifts the entire focus to the patient's experience. This is like a humanizing UX or user experience of medicine.
It's a vital reminder that a physical exam isn't something a doctor does to a passive body. It's something they must do with a human being. It requires a cooperative physical dialogue.
The very first instructions the medical student must memorize to start the examination are brilliant in their sheer empathy. The student is taught to ask, "Yahin dar tanahi?" Is there any pain? And "Koi naat masnui tanai?" Are there any artificial teeth?
Asking about pain first establishes immediate trust and safety.
Yeah.
You do not want to start aggressively palpating someone's jaw if that's the source of their agony.
Right.
And asking about artificial teeth is both a diagnostic clue and a critical safety measure, so you don't accidentally dislodge a loose denture while examining the back of the throat.
From there, we get into these fascinating, highly specific scripts the student must use to guide the patient. For the exam, they have a script explain the speculum. I will put this instrument in your ear. It's just telling the patient what is about to happen to lower their anxiety. Nobody wants a cold metal funnel shoved in their ear by surprise.
And you need the patient to remain perfectly still. Surprise leads to flinching, and flinching during an ear exam leads to injury.
Then there is the script for the Valsalva maneuver. The physical instruction here has to be so specific to work. Pinch your nose, fill your mouth with air, and try to push it into both ears when I tell you to.
The Valsalva maneuver is exactly what you do to pop your ears on an airplane. By having the patient forcefully do this while the doctor's looking through the otoscope, the doctor can physically watch the eardrum bulge outward if the eustachian tube, the plumbing connecting the throat to the ear, is clear.
Oh, that makes sense.
But to get that specific clinical data, the patient has to perform the physical action perfectly, hence the highly precise script.
They also have specific commands for checking the nerves. For the facial nerve, the instruction is simply grind your teeth. For the trigeminal nerve, it's I will touch this cotton to your face, you will point with your finger which part of the face you feel it.
Very clear, simple instructions.
And for the fistula test, it's look towards my forehead.
Every single one of these commands is designed to elicit hidden signs. Grinding the teeth forcefully clenches the masseter muscle, allowing the doctor to feel its strength.
Right.
Having the patient actively point to where the cotton touches them, rather than just saying yes or no, proves their sensory pathways are accurately mapping location.
Oh, because if they just say yes, you don't know if they feel it in the right spot.
Exactly. And having them lock eyes with your forehead keeps their gaze steady so you can monitor for that microscopic nystagmus eye flicking we talked about earlier.
What I love most about this specific page of the source material is that next to the commands for the Weber's test and the rebound test, there were just 2 question marks written in the margin, just a gap.
Yeah, that's my favorite part.
It is such a stark, charming reminder that this document belongs to a student. They're still learning. They simply didn't know the proper Urdu translation for those specific commands yet, so they left a placeholder.
It's a wonderful human detail. It reminds us that the physician is human, just as much as the commands remind us the patient is human. They are attempting to master an incredibly dense, physically complex diagnostic language, step by step.
When we pull back and look at this entire document, these humble handwritten checklists for short cases, it looks at first glance like a dry clinical to-do list. But it is actually a masterclass in treating the human body